Hi, everybody. Just so you know, I just started recording. Welcome to Grand Rounds for Rehabilitation and Movement Science for May of 2023. This month we have with us Dr. Kylie Heath. She's the Chief Orthopedic Physical Therapy resident with us right now, and she's going to be talking to us about neurocognitive component of return to sports for after ACLR, after ACL reconstruction. Dr. Heath earned a Bachelor of Science in Health Sciences, followed by a Doctor of Physical Therapy from the University of Sciences in Philadelphia. She's currently the Chief Resident in the St. Luke's University Health Network's Orthopedic Physical Therapy Residency. Dr. Heath has a special interest in working with athletes stemming from her time as a collegiate soccer player, and having seen teammates suffer season-ending injuries and suffering several injuries herself. She's developed a personal interest in rehabilitating sports-related injuries and optimizing athletes' return to sports outcomes. Her passion for sports not only guides her interest in rehabilitating sports-related injuries, but also preventing future injuries through advocating for appropriate return to sports testing and timelines to ensure optimal outcomes to reduce re-tear rates. So please make sure you sign in using either the QR code or the web code on the left side of your screen, or in the chat. So when we move to the next slide, it'll be in the chat box. For those of you wanting CE or CME credit, make sure you complete the quiz at the end and the course evaluation at the end. If you have any questions, please feel free to contact me, but without further ado, I will turn it over to Dr. Heath.
Thanks, Dr. Karaha. So we're going to be talking about the neurocognitive component of return to sports, specifically after ACL reconstruction. This is our designation statement and disclosure information if you need that. Today we're going to be talking about the statistics and risk factors related to re-injury following ACL reconstruction. Then we're going to discuss the current guidelines for ACL rehab at this point and current return to sports timelines. We're going to describe the changes in neurocognition and neuroplasticity following ACL reconstruction, and then we're going to discuss the importance of training neurocognition and how to efficiently challenge neurocognition through our interventions. ACL injuries most commonly occur in strategy sports that require high velocity cutting, pivoting, and decelerating. Most commonly, ACL tears.
All right, now hopefully everybody can see the slides.
All right, so I'll go back. So here are the learning objectives that we just kind of talked about. So again, we're going to go over statistics and risk factors, then the current guidelines, changes in neurocognition and neuroplasticity, and then we'll discuss the importance of training neurocognition and how to effectively do it. So ACL injuries, as I was saying, most commonly occur in strategy sports that require high velocity cutting, pivoting, and decelerating. Most commonly, ACL injuries occur with non-contact. These non-contact injuries are defined as a failure to maintain knee neuromuscular control while attending to an external focus of attention. So those typically, rely on highly dynamic visual stimuli, variable surfaces, movement planning, rapid decision-making, variable player positions, and environment interactions, as well as anything unanticipated coming from your environment. These non-contact injuries most commonly occur in sports such as soccer, football, basketball, and lacrosse, hence my interest in this area, and are more common in females than males. About 200,000 ACL injuries occur every single year in the US, and about 1 in every 3,500 individuals will experience an ACL tear in their lifetime. And that's just the general population of the US. That's not even talking about specifically athletes. Approximately $7.6 to $17.7 billion per year is a lifetime burden of ACL reconstructions in the United States alone. For the sake of today's presentation, we are just going to be talking about ACL injuries in an athletic population with the intention of specifically returning to sport. So talking about specifically ACL reconstruction in an athlete, we're currently experiencing suboptimal outcomes at this point. There are low rates of return to sport, with only 81% of athletes returning to sport, and of that, only 65% return to their pre-injury level of sport, and only 55% return to a competitive level of sport. There are also high rates of re-injury, with graft failure rates up to 30%. There is also an increased risk of ipsilateral ACL tears, about 4 to 15%, and contralateral ACL tears, about 5 to 24%. As you can see, there's a higher rate of contralateral ACL tears, which means that that is at risk, again, after you have an initial ACL reconstruction. In addition, individuals after ACL reconstruction are 16 times more likely to sustain a secondary ACL injury and up to 235% increased risk of a contralateral injury. Moon, one of the big groups in the world of ACL reconstruction, states that 1 in 17 secondary ACL tears occur within 2 years of the initial injury. So pretty soon into that recovery window do they experience these high risks of re-tear. And lastly, in addition to these low rates of return to sports and high rates of re-injury, there's also an increase in early onset post-traumatic osteoarthritis. So what could be at fault for these suboptimal outcomes in ACL rehab? Since 2012, there's been a big push in improvements in ACL guidelines, talking about graft types and rehab protocols. And in the last few years specifically, there's been a significant amount of research into the neurocognitive changes that occur after ACL reconstruction and the role that physical therapy can play in training neurocognition in order to allow athletes to return to sport and decrease rates of re-tear. Current return to sports protocols do not take into consideration neurocognitive factors that may influence secondary ACL risk. Current research and established return to sports testing batteries only assess closed skills, which are not effective or reflective of the demands on the field and therefore do not sufficiently challenge all of the systems required to contribute to an athlete's ability to return to sport. Any deficit or delay in sensory or attentional processing may lead to potential coordination errors, which could increase the risk of injury in a game scenario. This component of return to sports testing is not thoroughly challenged with closed skill testing. Biomechanical changes occur immediately following ACL injury. Following injury, there's a cascade of neuroplastic and neuromuscular alterations that increase reliance on visual feedback and cortical motor planning for the control of knee movement. This begins with bottom-up reintegration, which increases the cognitive load of simple motor tasks that were previously performed automatically. With this increased cognitive load for simple tasks, there is less cognitive availability for more complex activities, which results in an inability to maintain motor performance under high cognitive demands. Unless these specific components are trained and optimized, these biomechanical changes are present even after reconstruction occurs. So the current criteria to return to sports has patients introduced to running between 3 to 5 months post-op and to begin return to sports specific training 3 to 9 months post-op. Current functional assessments include the comparison of contralateral and ipsilateral quad, hamstring, and glute strength to be within about 90% of the contralateral side, hamstring and quad ratio greater than or equal to 70%, hop testing performance greater than 90% of the contralateral side, and utilization of the KOOS sports. There's also a battery of return to sports testing that could be performed. These tests include the hop test from the previous slide, in addition to the standing tuck jump, the Y balance test, the pro agility test, and the T test. For the sake of this presentation, we are not going to discuss the validity or normative values of these return to sports tests, but it's important to note that none of these tests account for neurocognitive processes. Another shortcoming of these tests is that they usually follow simple motor skills, which are based on reaction paradigms. We'll discuss why that truly doesn't challenge cognitive motor skills later in this presentation. And more specifically, none of these tests address working memory or inhibition control, which are more important skills required for the complex motor tasks of return to sports. So we've been talking a lot about neurocognition, but we haven't really described what it is. So neurocognition is cognitive processes or functioning understood in relation to specific neural mechanisms, and they occur in the brain and any impairments to these mechanisms. It can be broken down into 2 main categories on the left-hand side there: executive function and lower order cognitive function. In terms of executive function, important components that we're going to talk about are working memory, inhibition control, and cognitive flexibility. In terms of lower order cognitive function, we're going to talk about visual attention, processing speed, and dual tasking. So overall, executive function can be defined as the ability to coordinate cognitive, emotional, and motor processes to allow people to successfully navigate their environment by shifting and adapting to a changing environment. As stated before, this can be broken down into working memory, inhibition control, and cognitive flexibility. Working memory facilitates planning, comprehension, reasoning, problem solving, and is handled by the prefrontal cingulate and parietal cortices, or overall the frontoparietal brain. Inhibition control plays an important role in selective attention and is again modulated by the prefrontal cortex. And cognitive flexibility is the capacity to adapt strategies of cognitive processing to new conditions, and that's handled by the prefrontal and posterior parietal cortices. For lower order cognitive function, again, you have visual attention, processing speed, and dual tasking. These are necessary for larger executive functions to occur, so they're like a subcomponent of them. Visual attention is the ability to prepare for, select, and maintain awareness of specific locations of objects or attributes of a visual scene, and it's handled by the prefrontal, parietal, and temporal cortices. Processing speed is a basic cognitive function required for more complex functions like working memory and plays an important role in reaction time, and that's handled by the precentral gyrus and the cerebellum. And then dual tasking is the ability to perform 2 or more tasks simultaneously, and that's controlled by the prefrontal cortex. Now we've discussed what neurocognition is and the components that make up neurocognition. We're going to talk about the specific CNS adaptations that occur after ACL tear and remain after ACL reconstruction. So immediately after injury, there's CNS reorganization. We talked about those biomechanical adaptations that already occur. Afferent signal disruption is caused by that ligament rupture, and the efferent output is changed. That impacts reflexes and influences both involuntary and voluntary movement strategies. The loss of the peripheral efferent signals, in addition to mechanical compensations at the knee due to pain, swelling, range of motion loss, etc., all contribute to decreased gamma motor function, which comprises motor output and neuromuscular integrity. And they did TMS scans of the brain, which actually demonstrated that there's reduced cortical spinal excitability and increased intracortical inhibition immediately following injury. In the last few years, there have been a few studies that utilized fMRI to map the CNS activations in patients without any injury and those who have undergone ACL reconstruction. So the ones on the previous slide are things that they found immediately after injury, and these are things that are now found after ACL reconstruction. So they found that there is altered cortical connectivity between regions of the brain responsible for sensory motor processing and error correction, which would be the primary sensory motor areas and the cerebellum. There's also decreased activation of sensory motor areas, so there's not only connectivity that's poor, but also decreased activation of those areas. There's also increased activation in the visual and cortical motor planning centers, as well as an increase in the posterior, inferior, temporal, and lingual gyruses, which are responsible for visual processing. There's also an increase in activity within the contralateral motor cortex and supplementary motor area when generating basic knee movements, and higher activation in the premotor and primary motor areas during simple motor tasks, which indicates that there's not only higher activation on the ipsilateral side, but also concurrent activation on the contralateral side during basic movement tasks because it demands so much more attention. Lastly, there is increased activity and connectivity in the areas associated with visual spatial cognition and attention that is still present years after injury. So this is a change that's not just occurring in the acute phase after ACL reconstruction. These studies have demonstrated cortical mapping of the brain after ACL plays a super important role in identifying the interventions that we choose to challenge neurocognition in our rehab protocols. So this is a great demonstration of that cortical mapping on fMRI, and this was performed by Grooms et al. On the left, you can see that the regions they identified as having lower activation are the cerebellum and the ipsilateral motor cortex. And on the right, you can see that the regions identified with higher activation are the contralateral motor cortex, the lingual region, and the ipsilateral secondary somatosensory cortex. So it's another way to summarize exactly what I wrote on the last slide. So in summary, basically what those previous 3 slides described can be boiled down to 2 main concepts: the capacity sharing model and the sensory reweighting hypothesis. So the capacity sharing model is the idea that when the cognitive reserve is exploited by secondary distracting tasks, the attention can either be directed to the cognitive component of a task or the motor component of the task, and whichever one it's not decreases the efficacy of the other. In terms of application to this population, it describes that individuals after ACL reconstruction require a greater attentional demand for motor tasks, which means that if they are in a cognitively distracting environment, like a sports game, their motor skill is going to decrease due to them reaching capacity of their attentional demand. The other concept is the sensory reweighting hypothesis, which is the idea that there is a compensatory increase in reliance on visual processes in those after ACL injury, as evidenced by the fMRI studies. This automatic reweighting is explained by the disrupted afferent information provided by the articular mechanoreceptors, which we're going to get into on the next slide when we talk about PNS adaptations. So these 2 concepts describe that overall, there is an increase in visual processing and activation of visual processing centers of the brain, as well as an increase in the attentional demand of simple motor tasks or motor tasks on the other side. At the same time, there is a decrease in sensory motor processing and a decrease in overall corticospinal excitability. So in terms of PNS adaptations, immediately after injury, there's going to be altered afferent signals secondary to that tear, pain, swelling, etc. After ACL reconstruction, the ACL graft does not fully reinnervate. Therefore, there continues to be altered afferent signals permanently. If you have impaired or inhibited afferent input, there are going to be alterations in spinal reflexes, vestibular responses, and motor responses that need to be retrained. If we are not actively retraining them, then we are not going to make any changes to that afferent input. In terms of spinal reflex excitability, there are greater deficits in the H reflex starting at the time of surgery, and interestingly increasing as time from surgery increases up to 24 months post-op. This can result in prolonged quad activation deficits, which the quad activation is mediated by the supraspinal tract or the corticospinal tract, which, as we just discussed, corticospinal excitability is also decreased after ACL reconstruction. So that's why prolonged quad activation deficits are, so notable after ACL reconstruction. So we've discussed specific CNS and PNS adaptations that occur following ACL injury, but this graphic summarizes the sensorimotor adaptations just to bring home the concepts. So starting from the beginning, you have that sensory neuroplasticity, where your afferent input is disrupted and the somatosensory processing is altered. Then you have your proprioception, where you have inhibited joint position and motion detection, as well as depressed somatosensory contribution to motor control, which we saw on the fMRI, as well as with the sensory reweighting hypothesis. Next, you have motor neuroplasticity, where efferent output is altered and motor processing requires more planning and visual feedback, which again, fMRI studies showed an increase in those activity in those areas of the brain. Then you have your postural control, where there's decreased stability without visual feedback. And lastly, you have movement control, where there is a reliance on visual feedback in order to maintain your neuromuscular control. So overall, this can be summarized by three main adaptations that come after ACL tear and remain after reconstruction unless we do interventions to address them. These three adaptations are depressed or disrupted somatosensory input and altered somatosensory or sensory motor processing, increased visual processing to plan movement and maintain neuromuscular control, and increased cortical top-down motor strategies. So what can we do about these changes in neurocognition? So this graphic describes a proposed model for encouraging adaptive plasticity instead of compensatory plasticity as traditional models do. So you have your injury to the knee or the structural damage to the ACL. Then you have your neuromuscular control adaptations, which we just talked about at length, ultimately resulting in depressed sensory motor control and increased visual feedback dependence. So going down the left side, you have traditional PT or traditional training, which unless you are purposely training against it, is going to encourage utilization of vision for motor control compensation, which further facilitates compensatory sensory motor control. With current PT practice for ACL rehab, we are unfortunately currently promoting compensatory neuroplasticity. Traditional or ACL rehab has always focused on restoring musculoskeletal system to the pre-injured state by normalizing strength, range of motion, biomechanics, etc. There's very little emphasis on recovery of neurophysiologic changes of both the CNS and PNS. On the right side of the model, you can see the proposed pathway, which utilizes integrated sensory and visual motor training with emphasis on somatosensation via modified visual feedback. This adaptive neuroplasticity model encourages upweighting of the somatosensory system by downweighting the visual system to promote restored afferent function and improve neuroplasticity. So the question becomes, how do we challenge adequately neurocognition? The key concepts that we're going to cover in terms of how we can influence them are through external focus of attention, implicit learning, differential learning, self-controlled learning, and contextual interference. We're going to cover each of these independently, and at the end, I'll wrap up with some overall recommendations and tools for how we can challenge these effectively. So external focus of attention. One of the ways that we can challenge neurocognition is by shifting the focus from an internal to an external focus of attention. So over 95% of PTs provide instructions with an internal focus. Examples of how to do that, keep your knee in line with your toe, minimize the movement of your feet. For instance, when we're doing quad sets, you want to feel the contraction of your quad. But the research actually shows that external focus training may provide a means to restore some of these altered intracortical facilitation problems and increase intracortical inhibition, which are both, altered after ACL tears and then remain after ACL reconstruction. So ways that you can encourage an external focus of attention are by keeping the bar horizontal, asking the patient when they're doing a lunge to lunge. Instead of knees over toes, you're lunging towards an object, towards a cone that encourages proper body mechanics. So they are no longer focusing on exactly what their body is doing, but how they're moving. Implicit learning is a type of learning that reduces the reliance on working memory and promotes movement as an automatic process. We can all agree that that's extremely important in our athletes as they're trying to return to sport, because we don't want them consciously thinking about what they're doing. They need to be able to automatically do it. The research supporting implicit learning demonstrates that it does not specifically target corticospinal mechanisms, but it is shown to overall influence corticospinal function more generally. Overall, implicit learning promotes low conscious awareness, which increases neural efficiency and allows athletes to deploy resources to other aspects of performance. This is important because, as we spoke about already, the increased frontal cortex and premotor cortex activation, which demonstrates that there is a greater amount of attentional awareness going towards activities that should be automatic. Implicit learning could promote a change in those activities, becoming more automatic and require less attentional awareness. Here are some examples of how you could promote both explicit and implicit learning with a variety of tasks. Reading through these, I think you can see how we generally cue patients with a lens towards explicit learning versus implicit learning. I know I'm personally more likely to give an explicit clue unless I'm thinking about giving something implicitly. But I think it's important that we utilize both of these types of learning, explicit and implicit, in early PT, but then specifically transfer to implicit learning with higher level tasks in order to more promote that automatic unconscious response for movement. Differential learning promotes a more realistic environment for learning for athletes who are trying to return to sport. Athletic activity requires rapid and variable movement approaches that can be facilitated with a differential learning approach. So in most sports, it's rare to repeat the same movement for 3 sets of 10 reps before moving on to another movement. With that being said, movement patterns should intentionally vary during practice. So in terms of neurocognition, differential learning is associated with an increase in posterior alpha neuron activity, which increases, which indicates a greater activity in somatosensory working memory and a decreased reliance on attentional resources. So again, combating the things we just discussed are increased after ACL reconstruction. So below, you can see 3 examples of how you could promote differential learning. On the left are variations of a jump task. In the middle are changes of an environment, and on the right are changes of the athlete. So for instance, you could give, a prescription of 3 sets of 10 repetitions of a type of jump, but each of those 10 repetitions is a different type of jump. That way they are varying their practice and they are doing the same task, which is jumping, but there is a novelty to each part of that so that it is keeping their brain, cognitively adapting to all of that. Self-controlled learning is also a powerful tool when it comes to motor learning, and something that I think I could definitely do better at, and I think we all could do a little bit better about, giving the patient a little bit more control over what they're doing. So overall, self-controlled learning increases motivation and promotes a more active role in practice sessions. So in a research study, the group that had self-controlled learning had better accuracy on the transfer of a newly acquired motor skill, which is indicative of improving neuroplasticity with behavioral gains. So I think this is one area, like I said, that we could all get better in, and something extremely simple to change. So one of the examples that the literature showed was creating a list of 6 or 7 activities that you really wanted to do with that patient that session, or giving them a list of 12 activities you'd like them to do each week. Let's say you're seeing them 2 times a week. Say, okay, we have to get all 12 of these in. Which days would you like to do which activities? Something as simple as that will get them increased, their attention and their motivation increased because they have some say in what they do. So giving them control of their own treatment will increase that motivation and promote active participation, which will help outcomes, but also train neuroplasticity and neurocognition with such a simple change. And then contextual interference is the interference in performance and learning that arises from practicing one task in the context of other tasks. So for example, contextual interference increases from blocked type practice where you're doing the same activity repetitively, where contextual interference is low, to serial practice, to random practice where it's at the highest. It is important that we utilize all levels of contextual interference with our patients, ultimately progressing from a low level of contextual interference to a higher level as we get them back to a game-like scenario. Higher contextual interference may lead to initially poor performance on a task, but it does frequently lead to better learning compared to block practice. So ultimately that skill will improve at a faster rate than if you continued with blocked practice. Contextual interference also provides a unique method of addressing the visual motor and sensory motor neuroplasticity changes that we noted before by relatively shifting the level of sensory weighting away from visual system and utilizing proprioceptive or visual input. So these are the concepts that we just covered, and now that we've covered each of them, I'm going to go through those overall recommendations as to how we could utilize them easily in our interventions. For the sake of the next 2 slides, I've split the interventions into either internal interventions or things that the patient then will do with themselves, or external interventions where there's object manipulation or things like that. So in terms of internal interventions, the way that I've laid out these tables on the left-hand side, you can see the internal tool, and then in the middle column, you'll see the cognitive area of focus that we're trying to train. And then the next 2 columns are examples of commands or cues with gradually increasing difficulty or complexity of the task. So for focus of attention, we talked about we want to challenge that external focus of attention. Ways that we can do that, like we discussed before, are cueing them to keep their knee pointed towards a toe or towards a cone as they lunge, or the next advancements would be perform a lunge in the direction that I'm pointing. For single cognitive motor challenges, you could add arithmetic, you could challenge working memory, you could challenge auditory system by progressing them from something simple like counting backwards from 100 by 7s, or naming all the football teams, to something more advanced like having them answer math problems out loud, name the football teams in alphabetical order, things like that. One of the interesting things that I thought was cool from the research was that if you are going to challenge the auditory system, making it more salient by using commands specific to the sport or activity that they're trying to return to. So for instance, soccer, if you say something like ball, pass, man, something along those lines to promote a more salient neurocognitive challenge for them. And then you can get into cognitive motor dual tasking with decision making, going from single step to double step, having them go from simple tasks like performing one intervention if they see the number 3, or another intervention if they see the number 1, to higher level tasks where they have to perform a math problem, interpret the answer, and then perform the task specific to that type of answer. In terms of external interventions, same layout for the table. On the left side, you'll see the external tool, then the external area of focus, and then the progressive cueing for increased difficulty. You could do object manipulation, such as a ball toss or a ball dribble, again, adding levels of complexity as you go from a simple task to a more complex task. I kept this pretty simple in terms of advancement, but remember, for each of these stages, you could play with things that we've discussed from before. So you could change the environment that you're doing it in, you could change their body position, have them on 1 foot, 2 feet, dribble with their non-dominant hand, eyes open, eyes closed, play around with any of those things that you want to play around with. This is just an example of how you could manipulate one single tool. Perturbation training, going from anticipated perturbations to unanticipated perturbations that would most replicate your return to sport. And then we talked about differential learning, changing the environment, going from quiet treatment rooms to busy wait areas, changing the vision that we have, which we'll talk about on the next slides, and then changing your level of tension from relevant distractors to unanticipated distractors and things like that. And then lastly, you could do object or opponent navigation or avoidance, object avoidance being easier than opponent avoidance, going from throwing a tennis ball, making sure that it doesn't touch their body, to hiding behind an object and then sticking out something that makes them change direction and go the other direction. Overall, both of these internal and external interventions can be easily substituted into our current programs to ensure that we're utilizing some sort of neurocognitive lens. None of these discussed so far require, external objects that we don't already have in our clinic. So it really should be simple to implement, in our, daily treatments. So for the next few slides, like I said, I'm going to talk about vision interventions and how we can challenge the visual motor system effectively. So visual disruption is something that's getting a lot of attention over the last few years in terms of ways to challenge it. There are 2 ways that you can influence visual disruption, either directly through direct visual disruption or indirectly through indirect visual distraction. For direct visual disruption, utilizing something like these strobe goggles is going to be the best for stimulating that return to sports environment. So these strobe goggles are remote controlled, and depending on the complexity of the ones that you purchase, you have the ability to flash at different intervals in different lenses, different sequences, so that you can advance them from lower level to a higher level in terms of complexity of vision removal. What direct visual disruption does is that it challenges the neurocognitive system by influencing the visual motor system without removing it completely, as you would if you had the patient close their eyes. This direct visual disruption through the strobe goggles most directly simulates a sports environment where their eyes are rapidly moving and changing in terms of target, but are never fully closed. Indirect visual distraction talks about a lot of the things that we've already discussed in terms of changing the focus of attention, the task complexity, the visual input, and the cognitive load that you allow the patient to be under when they're doing specific exercises. So this indirectly will influence neurocognition by increasing the weight of the attentional component of the task, which will increase the cognitive demands of the brain, allowing the visual system to take a back seat and influence sensory motor and visual motor reweighting. Another thing that was discussed in the literature in terms of influencing that reweighting problem between visual motor and sensory motor deficits is that you can promote neurocognitive change of the visual system by influencing specifically visual motor interventions. For this, we can utilize a lot of the other tools that our NeuroPTs and OT friends have to challenge ocular motor control, multiple object tracking, visual sensitivity, spatial attention, visual memory, reaction time, and processing speed. By optimizing the visual motor system, we can reweight the amount of influence that the visual motor system plays in the control of movement. And these interventions should not be performed in isolation unless the patient is specifically struggling with one component of them. So this is something that you could add in while they're doing something else. So you can see in that top right corner, the athlete is dribbling a ball while having a visual motor task in front of them. This could be something that could be introduced in the beginning of ACL rehab, and then something that we can progress as we reweight that system as much as we can. And then this is just some tools that I wanted to put together. As I talked about before, aside from the strobe goggles, nothing that we've talked about requires us to purchase anything that wouldn't be already found in a clinic. A lot of it comes down to cueing, emphasis of sessions, and promotion of specific types of learning. Tools are cool and they can facilitate some of these neurocognitive principles, but again, they're not required to be able to do a lot of the things that we've discussed. So with that being said, Skills is a brand that I found a lot of really cool neurocognitive tools on. They have a lot of things when it comes to return to sports specifically, some of these being the rainbow colored circled agility ladder, the numbered and colored cones, the reactive tool that has colored and numbers on it, and then the reactive tool that has just the colors that you could have them catch. Like you can see in the top left corner, the girl is catching with a specific color that they're going to call out while dribbling a ball. So all of these tools can allow you to combine the principles we've talked about before in terms of levels of complexity and things that challenge working memory, attentional focus, multi-step commands, etc. But these are not required to thoroughly challenge the neurocognitive system. I just wanted to make you aware of some of them. All right, so thank you, and we'll open up to any questions.
Please feel free to either type into the chat or unmute yourself. One question that I have, do you find it difficult in the constraints of insurance-based healthcare to provide some of these services?
Yeah, I think some of them, once we get along to the end of your return to sports window, when they think that they should be returning to sports, getting the insurance to cover those end visits is sometimes challenging. But I think one of the things that the research talks about is how early we can introduce some of these simple neurocognitive tasks. So I think I don't think our rehab is lacking at the end component of challenging certain systems. But I think in the beginning, getting those motor learning tasks and changing the implicit learning and the direction of how we cue the patients could help get us to a better point by the time that insurance says that it's time for them to be done.
And I guess with that, as that occurs and as that transition goes from the surgeon and the PT to the athletic trainer, have you found any good ways of communicating where they are, not only from a quantitative perspective, strength, but also from a neurocognitive?
Yeah, I think that's an area that we could probably have a better conversation about when it comes to how to adequately still challenge these patients when they do return to a sports environment, making sure that I wouldn't say we have a good system set up to communicate that with them right now. I know that we have a program at my clinic for return to sports that we do utilize some of those longer, times that we get with the patient to help transition them, but I don't think there's a good way of communicating that we may have to look into, kind of making sure that those athletic trainers take into consideration that there is a component of this. And one area that I didn't even talk about that was in the research, it's still being, they've transitioned more away from, the fMRI stuff to this part of it, is seeing if there is a potential risk factor before an ACL tear even happens that would put you, from a neurocognitive lens, to put you at risk for an ACL tear. So if the research shows that there is something from a neurocognitive component that we could be addressing to prevent ACL tears in general, that may be something that we could talk to ATs about screening purposes and things like that.
So that was my question.
Yes.
Both with ACL deficient population and prevention, did you run across any?
Yeah, so for the ACL deficient population, these changes are still all present. So to a degree, like as far as like our biomechanics and the things that are happening at the knee, I think we're doing, the right things with coping and not coping, but this plays an important role in how we, should be rehabbing our patients as well. Because if there's that sensory, upweighting of the visual system, we need to train that in them equally, just because they're not going to get the surgery. They need to have that system be back to what it would be at baseline.
Thank you. One question online. Earlier in the presentation, you talked about return to sport testing, not including the neurocognitive component. So what are some tests we can use to test an athlete's neurocognitive ability following ACL injury?
Yeah, so I don't have a great answer for that at this point. There was a lot of, or there wasn't a lot, but a couple articles discussed potential ways that we could be doing that, but the outcomes weren't statistically different than the current return to sports tests, so they weren't saying they were the most efficient. But I would say if you can establish that you have made some sort of gains in their ability to control, then you could, you could play around with challenging, them with these hop testing with the strobe goggles on, or with, having them perform motor tasks while simultaneously doing it, kind of like the tug versus the tug cognitive, like adding that layer of it, although not necessarily with normative values at this point, you would see a fault in the motor ability of the athlete.
And then also, how soon should the introduction of this neurocognitive training be included into a rehabilitation program?
As soon as you see the patient, as soon as you see them. The earlier the better, because you can start those reweighting problems earlier, and I think it becomes a problem later on if you've gotten them to higher level activities and now you're like, oh wait, they are very reliant on their visual system to be able to do these tasks. So the earlier that you can get that kind of reweighting back to equal, the better for their outcomes.
Questions? Thank you very much again, and please make sure you take the quiz and fill out the evaluation form. In order to get both of those, you need to log in to EADS using either the QR code or using the login code. Thank you very much.